So our last panel speaker is Dr. Steffanie Strathdee. Pronounced okay? Good, great. Dr. Strathdee is an infectious disease epidemiologist renowned for her research on the intersection of HIV and substance use, having generated more than 700 scholarly publications. She is the Harold Simon Distinguished Professor of Medicine at the University of California, San Diego, where she has led research on prevention of HIV, HCV, and related infections among people who use drugs in Canada, the US, and most recently, the Mexico-US border. In 2009, she and her team were awarded the Leadership Award in International Collaboration from the National Institute on Drug Abuse, who also granted her a prestigious MERIT Award, Merit, for her substance use research in Tijuana? In Tijuana. English, ne? Mexico. Welcome, Professor.
Okay, everybody. I know that dinner is close and everybody wants their glass of wine. So I'm going to talk about some winnable battles. I know that we all talk about challenges. I have one slide on challenges. Hopefully the rest are going to be about opportunities, and I'll be building on some of the themes that my two esteemed speakers have already talked about. So where are we at right now? Well, it's a pretty dire place in the world right now. We have slashed budgets. The National Institute of Health, which is the biggest publicly funded organization providing research funding around the world, slashed budgets. CDC staff terminated. Funding at their and NSF, National Science Foundation, also slashed. Medicaid is under threat. The whole government in the US is shut down right now, arguing about Medicaid as one of the key factors that is supporting people who lack health care. And of course, PEPFAR. Peter Vickerman and his team have shown very eloquently, as we saw in the first speaker today, the impact that the lack of PEPFAR funding is having on what we have become dependent on here to provide HIV services and treatment. And university funding has been slashed as well, and there are compacts that the federal government in the US is asking that be signed in order for funding to be received. Terminations of grants with certain words and focusing on key populations. International funding has been cut almost extremely, and deprioritizing research on key populations and HIV, equity, diversity, inclusion, and finally in an executive order to end crime on American streets, which is really an attack on people who are homeless and those who are immigrants. So this is it's a pretty bad place to be right now. This is not just affecting the US, it's having ripple effects around the world. But I'm here to remind you that we have been here before. We have been in a place where our work and the people that we serve have been under threat. So in the early AIDS epidemic days, in early 1980s, late 1980s, we really did come together, and largely the gay community played a huge role in this, silence equals death being the mantra that ACT UP, the AIDS Coalition to Unleash Power, really weaponized that in a positive way. And of course, the AIDS quilt. That was the beginning when it hit that our communities that we are representing, people who use drugs, were dying of overdose, and it was not just affecting the average person; it was reaching into richer communities. We saw that people came together and really started making a difference. Now, and through these experiences, we saw that activism can work. I mean, those of you who are older in the audience like me will remember that needle exchange started with the junkie bond in Amsterdam. These were people who used drugs and ex-people who used drugs who came together and said, you know, we could do this better. And of course, that was the beginning of the harm reduction movement. Syringe services programs have flourished despite their challenges. Supervised consumption sites, also community activists played a huge role in starting those. And then more recently, heroin-assisted treatments as a medication to treat opioid use disorder. So, you know, these are our success stories, and I think that we need to remember them, and the institutional memory of those of us that were in these experiences early on are lessons that we can still learn today. I myself experienced some of this as an early postdoc in Vancouver. Some of my own research was used to keep the federal ban on congressional U.S. funding against needle exchange. And so these were Dear Congressman letters that were circulated at the time. Some of these policymakers still are around, but some of them have actually come around to support harm reduction because they saw in their red states that people were dying, people in their rich communities. So, there are lessons. Now, in 1998, when I was still a junior person at the time in Vancouver, published this paper, Needle Exchange is Not Enough, Lessons from the Vancouver Injection Drug Use Study. That paper was taken up by the Canadian government and used to expand syringe services, to expand medication for opioid use disorder, and that began as a real movement that started to change the landscape. It wasn't me alone. It was actually a lot of community activists and young researchers who stood up and said, look, we're not a silver bullet. We need institutions and resources around us. And that, unfortunately, you know, is a lesson that we are still having to learn over again, because when I look at what we're experiencing now, I realize that, you know, we thought that this was a sprint. We didn't think that it was a marathon. We thought we fight the battle once, we win, and we go back to what we were doing before. But you know what? These battles, they come at us over and over again. So that means that we need to think about the work that we're doing in a different way in order to ensure that we keep winning. So another example is safe consumption sites. Now, of course, Vancouver is not alone in having one of these facilities, and several of them not only exist in Canada and Australia and across Europe, but these have been under threat all along. And in fact, some of these slides come from Thomas Kerr, and the team in Vancouver are still fighting, and everybody around the world thinks, oh, well, you know, Insight is still open, so you know, Vancouver won. Well, there's been a resurgence of the folks that are trying to shut these down, and so across Canada, many safe consumption sites have been shut down, and so it's using data effectively and using community activism, and we as scientists have to be activists too. In this field, you don't really have a choice. And I was foisted into it in my early days and accepted that role. But those of us who have been reluctantly coming to the fore are realizing now that we have to come together to do this. So using data to make change. I'm going to show a couple of other examples that really relate to viral hepatitis. So in the early days, of course, we knew that syringe exchange programs were having an impact on HIV, but the folks in the UK, and Natasha at the time, but also Peter and colleagues, started to realize, well, look, we have these data, and we can actually see whether or not they're going to have an impact on hepatitis C. Well, they did, and they were shown to roughly have the risk. And but the data didn't stop there, because then you can take those data and, as we saw from our first speaker, model the impact that this would have if these programs are scaled up at various levels. And so you can see that when medications for opioid use disorder and syringe services programs are scaled up, you can have a tremendous impact. So these are some of the early data. And then Natasha Martin went on to expand on some of these approaches to think of hepatitis C treatment as prevention. And so not just curing at the individual level, but what impact that would have if these people don't go on to infect others because they were cured. Well, that work really, which was referred to in the first speaker, so I won't go on to it too much, has had a tremendous impact on how we think about this at a global level. And so the cost effectiveness threshold that we heard that from the first speaker was the comparator here. And you see, wow, compared to not having injected drugs or being an injection drug user, you can have a tremendous impact on hepatitis C transmission going forward. And so this was approach it got through to the World Health Organization. And up until this point, those of you in the audience who will remember that there were real exclusions for people who inject drugs who were no longer not being able to access hepatitis C treatments. Well, in the early days, those treatments were pretty lousy, but as DAAs came on the scene, it became absolutely urgent that we expand access to people who inject drugs. And so the WHO was convinced, not just the the effectiveness data, but the cost effectiveness data at a population level really drove that decision. And then, of course, the WHO started to realize, well, look, this needs to be thought of not just as Hep C, but viral hepatitis. So hepatitis B and hepatitis C elimination can be achieved. And these approaches were built into a strategy in 2016. And as you can see, some of this modeling work was directly informing that decision. But of course, we weren't done, right? Because these treatments were too costly. And some of you, again, will remember that it was shown, okay, well, these treatments work and they're cost effective, so how come people aren't getting them? Well, we really needed to turn ourselves into activists to make this happen, and that message got through. In many places, it was a continued battle, however, because in the U.S., where Medicaid really supports the majority of people who are disenfranchised and marginalized, they weren't receiving access. And this slide shows that in 2014, most of these states in the dark colors were those that had sobriety restrictions that required people to stop using drugs for a period of time, sometimes a very long period of time, in order to become eligible to receive hepatitis C treatments. Well, it was advocacy and activism and legislation and lawsuits, real lawsuits, that started to turn this around. So by 2024, you can see that there's only a few states that are left. Now, I'm not saying we should stop there, but one of the big wins was a red state, Alabama. And so that was a real win to try to, not just lower the costs, but to have activism play a role and to have legal action play a role to turn over these approaches that were extremely punitive and were denying huge segments of the population access to life-saving medications that would have a population impact. So there are other glimmers of hope, too. Now we actually have a World Hepatitis Day. People are talking about this, July 28th. In the U.S., even though I showed you that slide with a lot of challenges, there is bipartisan legislation for a national hepatitis C elimination program that is just slowly getting underway. And with the help from Unitaid and FIND, that there were investments to help roll out point-of-care testing for HCV RNA in lower and middle-income countries, and those have played a huge role, and I'll get to an example of that in a minute. But also in the US, the FDA granted a CLIA waivers so that the gene expert system could be allowed to be on mobile units and testing at point of care for hepatitis C RNA. And of course, when you do that, you can determine whether somebody's chronically infected in minutes and then link those people to care, as opposed to sending it out, finding out, whether or not they have chronic infection and then trying to find the person to get them linked to care. That is not going to work for this population. So, interestingly, when I asked ChatGPT to show me the countries that had any kind of near point of care or point of care HCV RNA testing, I was surprised to see this slide, and I actually had to ask around, is this true? The Republic of Georgia, before 2016? Well, it wasn't a countrywide program, but it was nevertheless a novel program. And look at all the other countries here too. Now, Australia is a special case, and thanks to Jason, I'm going to be able to give you more detail there. But Myanmar, Pakistan, Vietnam, Egypt, all of them developed programs before the US. So you don't have to be rich to make it work. You just have to fight, and you have to be innovative, and you have to keep fighting. But Australia is a special case, and it's really quite remarkable to hear the story. Initially, there were proof of concept studies that were showing that point of care HCV RNA testing could occur, and also that using dried blood spots would work, and that this could be done on a mobile basis, because when the COVID pandemic hit, there was a lot of testing sites around, and it was possible to leverage that kind of approach to integrate other systems like point of care testing for Hep C. But when I spoke to Jason through email, and he's in the back of the room, so he can tell you more about this story if you don't know it, it was actually a conference, and it was the Australasian, the 12th Australasian Viral Hepatitis Conference, that really was a catalyst in getting government engagement to support a national program for Hep C RNA point of care testing. And so that was the beginning, and it's taken some time, but the most recent data that he shared with me is that treatment uptake is 69%, 56% in the community, and 82% in prisons, and thousands of people have benefited from this. So, Australia is a rich country for some, but compared to the U.S., that hasn't even implemented their nationwide program yet. I mean, this really is a success story, and I congratulate Australia for doing this. But a lot of people have turned to me and said, okay, I can't speak up. I'm a junior person. I'm fearful of losing my job or losing my funding. What can we do? Well, there are other ways to speak up. Resistance takes many forms. Medical associations can play a major role, for example, because they are en masse a group of people who share a common set of values and have respect and authority. So, for example, this is an ad that's been put out by the American Academy of Pediatrics to support hepatitis B vaccinations, because vaccines are now under threat, and they have pointed out that infant Hep B infections have dropped by 95%. Well, that doesn't roll off the tongue of the average person in the community. We need to remind people of these successes. And, also former public health officials can play a role. So most recently, 6 surgeon generals in the United States, and these are bipartisan, these are folks on the Republican and the Democrat side of the aisle, spoke up and wrote an op-ed to the Washington Post to say that it's our duty to warn the nation about RFK Jr.'s threat to public health and to set the record straight. Now, that took tremendous courage, because this is a government that is actually retaliating against people. And those individuals who can't speak out, there's ways behind the scenes that you can give information to the press. I've done it myself, and still change that way. So take-home messages, I think, not just from this presentation, but from the last two as well, is that we have been here before, and we know what to do. You know, we have fought, and many of us have been fighting the same battles over and over again. So I think that what we need to do in this situation is realize that this is a marathon, it isn't a sprint, and we should know that we're going to be needing to justify our programs and using data to inform policy and incorporating modeling and collaborating across the aisle with people that might not share our values but have the desire to improve the health of the whole world. And that these collaborations are key. They should be between scientists, activists, policymakers, lawmakers, and the press. And it's conferences like this that bring those people together. They're small enough that you can have these conversations. Go up to somebody after a talk and say, hey, you know, I'd like to ask you more about this. Can you tell me more about that? And sometimes the germination of those ideas is where new innovations and interventions and approaches to overcome these challenges really occurs. And we need to acknowledge the need for sustained action given the fact that we are going to be experiencing this for quite some time. That the challenges that the U.S. government has put us in right now mean that we are going to be experiencing problems for a couple of generations. And one of my last points is that as somebody who's been in this field since the 1980s, I realize that it's a legacy that of resilience that we need to impart upon others. So that means that we need to train the next generation in order to be able to do the work that we do, not just the methods, but the actual doing and the resilience and the activism. We can't let that die. And that's not just for research. This is for community advocates as well, because you folks, you've been on the front lines, and some of the junior people coming up, they're seeing this for the first time. So tell them your story. Tell them how you were able to manage despite the circumstances in your local context. They need to hear it. So finally, at a conference like this, it's so important to don't just watch, to see, don't just listen, but actually hear, and don't just think, act. And finally, in addition to the many people that shared slides and insights and data, we have to remember there's a lot of people who aren't here anymore. They're activists, they're researchers, and three of my favorite activists, Jimmy Jarabji, Luke Sampson, and Tarek Zafar, are shown here. They're just three of so many, but they would want you to not mourn, to organize. So thank you very much.